So thinking about palliative care in the home is really kind of multidimensional because you can think about program development, which is your formal process, and you certainly have emphasized this whole part about a needs assessment and understanding the community. But I think then there's this other clinical component that you also have to teach people how to do a home visit, because as a clinician, I started off seeing patients in the home. It was very different than when I learned how to do patients' care in the hospital. And in the patient home, the very part about what's the work that you do before you see a patient? How do you prep? How do you find out information? Who are you calling? How are you confirming it with the patient and the family? And then when you're arriving, that first impression is so important, and kind of finding out, can they come to the door? How are you going to get access to it if they really can't get to the door? Is it a safe neighborhood? Do they have animals? Do they have not? Because how you treat their animals sometimes is how they're judging you of how you're going to treat them. Then there's a whole process of this family interaction that you've come to their house, you're a visitor, and the family and the patient might sort of say, here, have some coffee, have some tea, have this treat. But if you don't take that treat, then they won't let you see them. So there's this really interesting part of social etiquette that happens in a patient visit that's in the home very different, versus this whole program part, which is your needs assessment, understanding the community. If you're going to see different people, different cultures, races, how do you need to do that? Versus in the hospital, it's your territory, and they become, part of this patient mentality, and they kind of have to sometimes lose some of their adultness and can sometimes regress because this is not an environment they're comfortable with, they don't know what's going on, and they don't have the information they need. When you're doing care for patients in the home, it's really thinking about where you're going to go with these patients. This is the start of a relationship, a patient-clinician relationship, but still one that you have to sort of develop and sort of follow the guidelines of being respectful and thinking about how are you going to ask things and what are you accomplishing for each visit, and then thinking about for your hospital, what are the guidelines that you would have of outcomes, but in the home sometimes they're a little more subtle, and thinking about pain and symptom, but maybe you're also going to have to really think about integrating a lot more of the patient's customs and traditions that you might not have picked up in the home. And then really working with administration. I think this whole piece that we've been thinking about caring and empathy is really important to kind of be present in a very different way for being in the home. So you have to really think about the staff that you're hiring, that they are experienced or willing to learn, and sort of a humility in that, that they're also going to have the expertise that they need to be doing palliative care skills, pain and symptom, but also a lot of primary care skills. And so there's this whole staffing and program design, and then just part of this human nature of this contact.